Okay, you should be good to go.
Okay, thanks, Vicki.
I'm done, right?
Oh, you gotta love technology. Okay, so this is mechanical ventilation. There's some things at the beginning that you can just review. It'll be on the PowerPoint, the answers. Okay, you can fill it in after. It just takes a while to go through it, so you can do that independently. You can try to answer them ahead of time, and if you can't get the answer, they'll be on the PowerPoint that I'll put out for you.
Rocky, no.
Okay, so the first thing we're going to do then on your sheet will be on page 2 of your notes, and it's respiratory failure. And really what we're looking at here is at what point do we get where we need to be put on a ventilator? You know, at what point do we say they're not doing well enough and they need to go on some type of ventilation? Well, really what we're saying is their oxygen demand and their CO2 exchange cannot keep up with what the body needs. And so you're seeing a PaO2 of less than or equal to 60, and you're having a PCO2 greater than 50. Remember, our normal PCO2 was 35 to 45. So we're definitely gaining here on the CO2 part, and we're definitely lagging on the oxygen piece. Also, our pH, we tend to become more acidotic when we have respiratory issues. So a lot of your ill patients in the hospital, you really don't see a lot of respiratory alkalosis. You see more respiratory acidosis with sick patients than you do with anything. So that's essentially what we're saying there. The CO2 and the O2 cannot keep up. So your book does do some comparison on respiratory failure. So things that impede airway flow, excuse me, some type of airway obstruction. Your book also talks about respiratory diseases like COPD and asthma. Talks about neurological impairments, Guillain-Barré, stroke, drug overdose. All of those could impede how well you can take in airflow. Possibly a chest wall injury, maybe a pneumothorax, maybe a flailed chest. Maybe you were in an automobile accident, had a crushing injury to the chest, and you have multiple broken ribs that are severely fractured in a couple different places, and you really can't breathe at all with that flailed chest. It definitely is going to impede how well you can breathe. You have a pneumothorax and the lung is completely collapsed. You know, that's going to impede definitely how much airflow you take in. Your book also talks about impaired diffusion or blood flow. They talk about alveolar disorders like pneumonia and COPD. They also talk about pulmonary edema, somebody that has heart failure, maybe they had a near drowning, they have ARDS. And then the last one, and I think in your new book that kind of put this under the blood flow portion, but when you have a ventilation perfusion mismatch from like a pulmonary embolism, it does affect both airflow and blood flow. So it's like a combination of both. Regardless of whatever is causing the problem, it always leads to hypoxemia. So what is the treatment that we're going to do for these patients? Well, first we're going to try oxygen. So Heather comes into the ED, she's not breathing very well, or O2 sat is kind of low. We're going to put oxygen on her, put a little nasal cannula on her, we'll see how she's doing. She doesn't do well with that. We might change her to a mask or do something. Eventually, it comes to the point where none of those things work, and we might have to artificially ventilate her. Another thing we would be looking at is some pharmacological intervention, mucolytics, bronchodilators, steroids, antibiotics. The problem being with antibiotics and mucolytics is they don't work really fast. The steroids help quite a bit, and the bronchodilators can help if it's going to be effective. But sometimes those things don't always remedy the situation right away. Treatment of acidosis. You have a buildup of lactic acid. We need to correct that either by ventilation. We have to make sure that their kidneys are working well so that they can help decrease the acid also. And then treatment, the last thing would be treating the underlying disorder. What originally caused the problem and what can we do to remedy the situation? So the first column that you have there is all of the things eventually come to impeding respiratory failure. And what are some earlier things that maybe you could recognize where you could call a rapid response or a race so we could get them to the unit, maybe get them on a BiPAP or CPAP, something like that that would keep them from being intubated. So the first one with hypoxemia, dyspnea, cyanosis, you might see signs of restlessness and apprehension, maybe confusion or impaired judgment. You might see increased heart rate or some type of dysrhythmia start to show up on your tele, increased blood pressure, and then a metabolic acidosis. For hypercapnia, your book talks about dyspnea and respiratory depression. We talked about headache with the hypercapnic patient. Papilledema, probably you're not going to see, but the physician or the PA or the NP might. Maybe an increased heart rate or high blood pressure. Drowsiness, and we said, remember, they can be comatose state. Systemic vasodilation and heart failure. And respiratory acidosis when we would do blood gases. Okay. The criteria then for putting the patient on the ventilator is their PaO2 cannot be brought above 50 millimeters of mercury with an FiO2 of 60. FiO2 is just a fraction of inspired oxygen. Instead of saying liters, we say a percentage. Their CO2 levels are greater than 50. Their pH is below 7.25, and their respiratory rate is sustained at 35 per minute or higher. So we know when people have blood gases or respiratory rate or a pH of this, they're not going to be able to sustain their own respiratory system for very long. They're going to have some type of artificial support. So those are the criteria that your physicians are looking at. We have a couple of different options for our patients. We have two different types of ventilators. One is a negative pressure ventilator, one is a positive pressure ventilator. A negative pressure ventilator are chambers that fit tightly across the thorax and abdomen. They create a negative pressure by eliminating the air. The chest expands, the air flows in, and then they passively exhale. They do not need to be intubated. Those are three different types. One would use this, somebody that might have Lou Gehrig's disease, somebody that might be a post-polio syndrome, Guillain-Barré, something where their musculature is weakened and they don't have good chest support. So if I had post-polio syndrome, I might be good during the day, but after I breathed on my own all day, my chest muscles are weak and I need some type of support during the nighttime. And we could put you on a negative pressure ventilator. So I'll show you a picture here in a minute. So here's what they look like. You can kind of think of it as a set of dentures. So do everybody's dentures fit everybody? No. The negative pressure ventilator does not fit everybody either. We definitely have two different body shapes right here. One person's body, their chest is long and skinny. The other one looks like they more have a little barrel shape to them. So they are made specifically for each patient. There's a company in Cleveland that would come down and take your measurements, and then they would build this device for you. Here's a archaic picture, but essentially it is the same thing. So this sits on the chest, and when the device kicks on, they're much obviously smaller than this, more compact. It draws the air out, and when it draws the air out, it pulls your chest upward, and you draw in a breath of air. And then the machine cuts out and you passively exhale. Okay, just for a little extra support for the patient whose musculature cannot support their own inspiration and expiration 24/7. So again, they may only need to be on it, 12, 14 hours a day, or they may have to be on it 24 hours a day. Just depends on the patient and what their disease process is. Here's an iron lung. Google those. There are some videos. There are patients still in the United States that are in an iron lung. They no longer make them. The difficulty they have are getting pieces and parts for them. So there would be a pillow here. The patient's head would come out here. It would lay on the pillow. Here's a mirror, a rear view mirror, so you can see who's coming up behind you. Here's windows that the nurses can work through. Here's the machine. Your body lays in here. And then the machine kicks on, it draws the air out of the machine, your chest rises, it kicks off, you passively exhale. It's the same as this and this, only less cumbersome. Because this is huge and weighs a lot.
Why would someone want to still be on that then, as opposed to the other thing?
What is the reasoning? I have no idea, to be honest with you. There is a video that I recently saw on Facebook of a lady that's in one, and I don't know if she has post-polio issue, but she's been in one for a long time, and she just likes it better than the other device. Because they asked her, why don't you switch over? And she's like, this is more comfortable to her. So I don't know if this one is more restrictive, like you can't move around as much, or maybe you lose the suction, where this one, she could move around in the capsule all she wanted to, because it wouldn't matter what position she was in, if she laid on her side, whatever, it would still work, because it's still pulling the air out of the whole device. So I don't know. These are archaic. I saw one in the 80s on a young man that was on a motorcycle accident. And I haven't seen one since. And he eventually died of pneumonia in his late 20s. But there are still people that use them. They just are having a hard time finding parts for them. But that might be a good extra credit one to look up and kind of watch some videos on. It just would be interesting to see their stories and why they're using it and why they still use it. All right. Our next type of ventilator are the types that you're going to see in the hospital. They require intubation. The expiration is still passive, and they're used with clients that make no effort or those that need a little bit of support. So on our positive pressure ventilators, we have all kinds of bells and whistles that will be going off. We have sensitivity settings. That's the amount of effort needed to initiate a breath. So it will tell RT how much effort you're making. Airway pressure, low versus high. Low pressure tells us that the air went in way too easily, and that usually means it's disconnected. The tube is popped off. A high pressure means that it's meeting some type of resistance, and that could be because the patient's chewing on the tube. There's a kink in it, there's moisture, all kinds of things could be causing that. The modalities of ventilation are also listed in your book if you need a little more explanation on it. But in an assist control, or AC or ACV, these are used most often. The patient can trigger the breath, but if the patient does not initiate one, the ventilator delivers it at a preset rate and volume. I want you to circle the word control. And I want you to put that the ventilator is in control, not the patient. So the disadvantage to having an assist control or an ACV type modality is that you personally can make no adjustments. So if you want to take a nice deep breath, the ventilator won't let you do that. It's a preset rate, a preset volume. Patients don't tolerate assist control very well without having some type of sedation on board, because that ventilator is giving you your breaths, maybe when you don't want to take a breath, so you're over breathing it, you're bucking it, you're out of sync with the ventilator. So most patients do require some type of sedation when they're on this. So this is usually in the most acute phase of respiratory, especially respiratory failure. They might get put on this so that you can rest. They're a trauma patient and they need to be intubated. Severe stroke patient, they may be put on this assist control with sedatives so that we just actually rest the body and let the body heal a little bit so that they don't have to make any effort on their own. The next type is a synchronized or SIMV. So synchronized intermittent mandatory ventilation. The tidal volume and the rate are preset. It allows for spontaneous breathing by the patient on their own tidal volume and rate. However, if they fail to breathe, there are a preset number of breaths that are given. And these are great for weaning. So in your assist control, we use the old saying that if you don't use it, you lose it. So the longer you're on an assist control and the ventilator is doing everything for you, the weaker your chest muscles get, the longer it will take for you to get off the ventilator. If we use a synchronized IMV and you're breathing on your own and you're using your chest muscles to breathe in and out, you maintain that chest strength. So weaning you will be a lot quicker in an SIMV modality. Some patients, however, cannot be in that because they can't breathe on their own at all. Their disease process, they're either too sick, they're too traumatized, something that they cannot breathe independently. So some of them are just not candidates for SIMV until they're down the road 2 or 3 weeks, if they ever are. If they're a C-spine fracture or something like that, they're always going to be on assist control. They never can initiate any breaths on their own. CPAP and BiPAP, your book talks about those too. All is spontaneous breathing. It can be an endotracheal or a face mask. These are modalities that you can add to their tubes, but they don't have to be intubated to have these. BiPAP is oftentimes worn at night. It helps with inhalation and exhalation. I think we all know people that have CPAP or BiPAP machines, so those are pretty self-explanatory for what they do. So if you call a race or a rapid response, and they take you to the ICU, we may try a BiPAP or a CPAP first and see if we can maintain your oxygen levels. If you can't, then you may end up getting intubated, but it is something sometimes they will try before they actually tube you if we have enough time and you're not having any, dysrhythmias or anything related to your breathing. If we have a little extra time, they could try these so that we don't have to tube you. A lot more complications come when we have to put a tube in. Okay. Now, when we have ventilators, usually they are not standalone on the buttons that they push. So they're not just in assist control, they're not just in SIMV, but there's some other modalities that we push the button and we add to it. And your book talks about some of these also. One of the main ones is a PEEP, or a positive end expiratory pressure. What it's telling you is that when you exhale normally, he may have talked about it in anatomy and physiology, but you never completely exhale all of the air in your lungs. It never falls to zero. Well, in a PEEP modality, it's even more than that. You retain even more air in your lungs than you normally would on an exhalation. And the theory behind that is that if you can retain some air, you retain some oxygen. So if you've retained air and oxygen, hopefully we can turn down your oxygen level just a little bit and we don't have to use as much O2 on you. Because we do know that too much oxygen is toxic. It can damage your lungs. Okay, we call it oxygen toxicity. Now, your second paragraph under your PEEP does tell you on your next page maybe that there are some disadvantages to using PEEP. And the disadvantage would be, if I have COPD, what do their chests look like? Right? They're already puffed out, barrel chest. They already are retaining too much air. So if I keep even more air in there, I'm risking exploding their lungs. They don't really explode, but they might pop a hole in them. We call it barotrauma. So COPD patients are a no-no. The next group of people who are no-nos are people that have a decreased cardiac output or hypovolemia. So, when you have return of blood flow to the heart, it is helped by your lungs inflating and deflating. So here's your pumping action on your great vessels. This is your lungs inflating, okay? Deflating, okay? Inflating, deflating. If I have PEEP and they don't totally deflate, I have a very, okay? Because my lungs aren't totally going, zzz. This is normal. See how much blood flow would get in there because I have a bigger deflate? Now I have a small deflate. I have a lot less blood return because my lungs are partially hyperinflated all the time. The squeeze is not there. It's there, but just minimal. We want a nice big squeeze. So if you're already decreased cardiac output and decreased blood flow, you don't want a gentle squeeze. You want this. So we would not use PEEP on those patients. Okay? All right. That's PEEP. CPAP, you know that one, continuous positive airway pressure. Again, they don't have to be tubed for that, but they can add it to the tube itself. Here's your BiPAP or CPAP. Some alarms. When an alarm sounds, what is your top priority action? It is assess. apnea alarm, they failed to breathe. Oxygen alarm goes off, it's not connected properly, or it's not sufficient. High pressure alarm, they're meeting some type of resistance. Remember, I said something's blocking it. So, factors that are occluding the tube. If you have secretions, what's your action?
Suction.
You're going to suction. If you have a kinked ET tube, you're going to unkink it. If the patient is biting the ET tube, you're going to put in a bite block. If you have water in the ventilating tubing, because we have tubing that's coming from their ET tube or trach over to the machine, and your oxygen flows through that, you get condensation, and that's the water we're talking about. We're just going to empty it. There's a reservoir bag, or you can empty it right into the trash can. You have a kinked vent tubing. Unkink it. And you have a prolapsed cuff. Remember I showed you the one picture where the cuff was blown out over the top of the tip of the tube? You would have to change it out. More than likely that would be a trach tube, because it would have been in a lot longer than an ET tube. And then factors that can increase your intrathoracic pressure and cause the high ventilation alarm to go off would be bucking. We talked about they're not in sync with the ventilator. The ET tube is migrated down into the right bronchus. Remember, it's shorter and wider. So if you aspirate anything, it tends to go down on the right side. Bronchospasms. Maybe borrowed trauma, they have a collapsed lung. Or a decreased compliance where the lungs don't really want to stretch. Okay, so all of those things can cause the high pressure alarm to go off. The easiest ones are in the number one. It's kink, there's water, they need to be suctioned, whatever. If you can't get those remedied, then you'll have to start looking at these other things. All right, so now the low pressure alarm goes off. Usually that indicates a disconnection. I have it bolded in black for you there. Okay, so a large percentage of the time, the tube has just come off, and all you need to do is put your tubing back on your ET tube or your trach. So if it's disconnected, you reconnect it. How about if you have a cuff leak? Well, try to reinflate it and check the pressures. If all else fails, you might have to change the appliance. And again, a lot easier on a trach than it is an ET tube. So that's why they have cuff repair kits for like ET tubes if something needs to be repaired, because it's a lot easier to flip a trach tube out than it is to pull an endo tube out and re-intubate them. How about extubation? Well, we said bag them. We don't know if they need to be retubed or not, but prepare for re-intubation. How about tracheostomy expulsion? Well, replace it if it's old. If it's new, bag the patient. You may need to open up your kit. You may need to use your dilators or your forceps. Hopefully you don't. Hopefully you can get a new one back in pretty easily. But if it's an old one, no big deal. Open a new appliance out or up and put in that obturator and put your new one in. Right, low exhaled volume. The ventilator detects that the exhaled volume is below the alarm limit. Just check the depth of the respirations. A lot of these things RT's in and out very often on a ventilator patient, especially when they're first put on, to make sure they're tolerating it right. We're making sure that the settings are okay. But when you have an alarm going off that you don't know what to do with, call RT, call the more expert nurse that might be around and they can help you out. Just don't panic. And then your low exhaled minute volume is the minute volume is below what was set on the alarm. And so you get a ding-a-ling for your vent. If the alarm is sounding and you cannot detect or correct the problem immediately, manually bag them with a high FiO2 while a second person checks or calls for assistance. So don't panic. Okay, all you want to do is make sure you're providing their airway. All right. Blood gases, they're done 20 minutes after we put them on a ventilator or 20 minutes after we make any changes. Respiratory acidosis tells us that we're underventilating them with too small a volume. Carbon dioxide is being retained. If we have respiratory alkalosis on our ABG, it tells us that we've overventilated them and we've blown off too much CO2 and the patient has become alkalotic. Changes in the settings are guided by the patient's baseline, whatever they were possible before they put them on the ventilation. RT makes the changes, not us. pH changes can alter their electrolytes. It can affect the action of a lot of their medications. It can cause arrhythmias for patients. It can cause neuromuscular irritability, and they can have seizure activity from it. So, we want to be as normal in their ventilation as possible. What do we do as the nurse? Well, we keep the patient as calm as possible, administer sedatives if needed, and restrain only if they're needed. It could be a chemical restraint or a physical restraint. We already talked about the lip line. The change side to side every 24 hours. And so we don't get breakdown on our tongue, the corner of our mouth. Auscultate breath sounds. Make sure you have bilateral breath sounds. Make sure you know what the ventilator settings are. When RT makes a change, they will come to you and let you know. And then you need to report that to your off-going shift nurse. Okay? The person that's coming on, you need to tell them what the settings are. Cuff pressures, we don't really monitor those, but RT will let you know if there is an issue. We can drain the water out of the tubings. Sometimes it'll sound like you're percolating coffee in the room, and you don't want that because that's interfering with airflow, so you can just drain the condensation. And then monitor arterial blood gases. There are some intensive care units where the nurses will draw their own ABGs. If your patient has an A line, and when I say A line, I mean arterial line, you, the nurse, can draw the ABGs. They do not have to poke the patient again to get arterial blood. You can draw. Respiratory will not draw it, but nursing can. Okay, now your patient's got to be intubated. How are we going to get that tube down their throat or in their nose? Well, we're going to use some type of neuromuscular blocking agent. And the drug of choice for the most part is succinylcholine chloride. It is highly effective. It will cause paralysis within about 1 minute. So the reason why I tell you that is when you as the nurse are pushing succinylcholine, you need to make sure that physician is ready to intubate immediately. That doesn't mean give succinylcholine and then they're like, well, the bed is too high, or I need the back of the bed off, or I need this, or I need that. They have to be ready to go now. It is a paralytic. The antidote for it is a succinylcholine inhibitor, which is prostigmine, and they'll usually have it in their intubation bag or their drug box. So wherever you pulled that out of, that antidote will be in there, okay, in case they need to give it. The second type of medication is a sedative or hypnotic, etomidate. Short-acting sedative, and it can be used for intubation. Some physicians like to use both. It's just preference. Okay, it's just a preference on which they use, whether the succinylcholine alone or they use succinylcholine with etomidate. But oftentimes it's given with the succinylcholine to help as a sedative. A general anesthetic oftentimes is given once the patient is intubated. We call it Diprivan or Propofol. It is well tolerated by patients. It's used in a lot of your ICUs for sedation for mechanical ventilated patients. We can give it in pretty small doses. I don't have this on there, but the one thing I do want you to watch for is it causes hypotension. So unfortunately, if Bianca is in the ICU and she is having hypotensive issues, Diprivan will not be our drug of choice. We'll have to use something like a Versed or something else to keep her calm and sedated, because this will not, she'll drop even lower. So the negative to Diprivan is that it causes hypotension. Now, if you're 150 over 80 normally and it causes a little hypotension, now you're 120s over 70s, it's no big deal. But if your blood pressure's only running 90s over 50s anyway, and we hook up Diprivan to you, chances are you're going to be in the 80s over 40s, and that's not good perfusion. So we won't want to utilize that. Okay. Other medications that we can use, morphine sulfate, Valium. I don't have Versed on there, but I do want you to know that Versed is a medication that we can give as a drip for sedation. Versed. Like I say, if they can't use the Diprivan or that, you might see a Versed drip utilized, but they try to use the Diprivan if they can, because it doesn't have very many side effects other than the hypotension to it. Patients tolerate it pretty well. Okay, bucking the ventilator. Client is out of sync with the ventilator. Variety of reasons. They're triggering the ventilator faster than it's wanting to breathe for them. They're out of cycle. They're trying to inspire while the ventilator is doing an exhalation. Just a lot of reasons why they don't tolerate it very well. And that's usually in that ACV, that assist control modality. So oftentimes when they're in ACV, because of the bucking of the ventilator, they have to be sedated. You have to give them something. Now, if the patient is unresponsive completely, we're not going to need to sedate them much. But if you take a fairly alert patient and you've intubated them because they've had an MI or something, once they start to wake up and you keep them in that assist control, you probably are going to have to sedate them because they're not going to like it at all. Some possible causes, I have there on letter C for you. They need suctioned, they're not getting enough oxygen, they're retaining too much CO2, their minute volume is not correct, they're having fluid buildup within their lungs, and then they have a lot of anxiety. So all of those things could cause problems. Remember, you want to use the least amount possible, so you can use neuromuscular blocking agents. You can use propofol for them. You may have to restrain them. ICU is one of the few places that you can still use physical restraints. You do have to have a doctor's order once every 24 hours to keep using them, but you utilize it as a harm to themselves, is how you rationalize it. So physical and chemical restraints are still okay within the ICU with very little explanation as to why you're using them. I mean, if they're intubated and you say the risk is they're going to pull out their tube, that's good enough to mark down. Okay. Nursing care, we want to prevent complications of immobility. You're going to reposition them, range of motion. If they are alert and oriented, you can get them up into the chair. If they're not, obviously, if we have Diprovan or something on board, you can't get them up into the chair because they'll just slump for you. But as long as they're with it, you can move them around. Hygiene, good basic hygiene, good mouth care, tube care. Providing rest and sleep. A lot of sensory overload, bells and whistles when you're in the ICU. Manage your treatments, manage time when they don't have interruptions. Sedation if necessary, or something maybe at nighttime so they can sleep. Nutrition-wise, poor nutrition causes a lot of issues for our ventilated patients. They can have atrophy of their respiratory muscles, decreased resistance to infection. Remember, just basic IV fluids only account for about 500 to 600 calories a day. They're critically ill. It accelerates their metabolism, so they're going to need some type of probably dietitian to come up and take a look at what their labs are. What are their serum albumins, their prealbumins? Are they already malnourished? Are they risk of malnutrition? And get them on some type of supplemental feeding. Remember our COPD patients, carbohydrates do metabolize to CO2. So we want to use some type of nutrition that is specifically for the respiratory patient. Pulmicare, Nutravent, something like that, and you have that in your notes. Methods, of course, we talked about G tubes, and J tubes are probably the best because they bypass the esophagus. A J tube is even better because it bypasses the stomach. They decrease the risk of aspiration. Your initially tubed patients that aren't going to be on a ventilator, hopefully very long, will have an OG tube. So it is just a nasogastric tube that we put in their mouth. And they'll feed them via that way. Now, they have to have it for, 10, 12 days. They'll probably put some other type of feeding tube in. But initially, they get an orogastric tube, which is just the NG tube that they insert via their mouth. So just keep that in mind. That's probably what you'll see on the initial intubation. And then if they decide they're going to be intubated a longer period of time, they'll probably switch that tube out. Stressors, you can read over these. Knowledge deficit, lack of privacy, loss of control, inability to communicate with you, sense of being an object, fear of the unknown. Okay, all of those things come to play, and it all leads to panic for the patient. So again, having something to kind of calm them down, some type of anti-anxiety medication is helpful. Complications of being on the ventilator. Well, the first one is barotrauma. That's the rupture of the lung. They can get subcutaneous emphysema or crepitus, which is just air in the subcutaneous tissues. Those can cause an airway obstruction if they progress. A barotrauma can cause a pneumothorax or a collapsed lung. If pressure builds up within the chest wall, they can get what they call a tension pneumothorax, and that is in a medical emergency. And we'll talk about that when we get to chest issues. For a pneumothorax, they would complain of chest pain. Your assessment would show unilateral chest expansion and breath sounds. They oftentimes have a change in their heart rate and their blood pressure. So that would be a very good indicator that something's going on internally with the patient. GI issues, your book talks about GI bleeds with patients, gastric distension due to possible air leaks, medications that slow the GI tract. You know, if the medication slow the patient down, you know it slows the bowels down too. Although once you give a tube feed, it kind of counteracts that because your tube feed patients tend to have the diarrhea. That's the only downfall to a tube feed. Infection, your book talks about nosocomial pneumonias. Those are hospital acquired. You know, changing the aerosols and the tubings per the protocols. Those need to be followed. We really don't want to skip those. And RT is good about keeping up on that, but we want to make sure that we follow up with it also. Decreased cardiac output. This often is frequently affected when they're put on a ventilator. We talked about PEEP. That's number one. Okay, I talked about that milking action. We already discussed that. Number two, because of how the lungs are filling, it limits the expansion and the filling and an ejection of the ventricles. So it actually can impede the ventricular ejection that the patient has, especially when there's a high chest pressure in there. Restricted blood flow. Restricted blood flow, especially when they're on PEEP again. So PEEP is a good modality, but for some patients it can be real detrimental because it reduces that return blood flow to the heart. So if you're having problems with blood pressures, cardiac outputs, urinary outputs, those kind of things, the physician may need to readdress keeping them on that modality. Fluid retention, unfortunately, when a patient is on a ventilator for a long period of time, they progressively do get fluid retention. We believe antidiuretic hormone is stimulated somehow, possibly due to the decreased cardiac output that occurs, and they start retaining more fluid. So I've never met too many patients that don't complain about, oh, my hands feel like I've got some edema, or my rings don't fit very well, or oh my God, look at my ankles. I never have had swollen ankles, but yet being in the hospital and the additional fluids and the decreased activity tends to assist in getting that edema. So you just want to watch that, especially on your ventilated patients. With that decreased return to the heart, they can also have pressures that increase within the head. So you do want to do neuro checks on those patients as best you can. Now, if they're sedated, it's going to be hard to do neuro checks unless you reduce that sedation and come off of it, and then assess their LOC, those kind of things, and then turn their sedation back up. That's kind of up to the physician, because some studies will say that that's hard on the patient to put them in and out of the sedation. So you'll have to see, sometimes they'll come in and they'll say, we're going to do a time period of no sedation and see how alert they become, see if they can answer questions. I shouldn't say answer questions, but can they follow commands, those kind of things, and then you resedate them. That's kind of up to the physician to decide if they want to assess that or look at it or not. And then our last thing, our weaning from the ventilator. You want to know what their clinical status is. So have we remedied why they got put on the ventilator in the first place? Did they have a major infection? Did they have a COPD exacerbation? What actually caused them? Did they have COVID and now they're better from it? What's their respiratory rate and the extent of their dyspnea? You know, if their respiratory rates climb into 30 plus a minute, they're not going to be able to come off. Do they have stable arterial blood gases? And do they have stable vital signs? So in your book, you do have a couple of methods listed. One's a FAST method or T-piece trial, and the one is an SIMV modality. And it does talk about it, I think, on page 1378 in your book. Talks about weaning. But this is it in a nutshell. That page there is not correct. That's in your old book. But it's on page 1378 now. So the FAST method T-piece trial is the choice for those that have been intubated for only a few days. And what we're going to do is put this T-piece on, and your book shows a picture of it. It looks just like the letter T. It's kind of a blow-by tube. And they'll connect that to humidified oxygen at the same percent that the patient was on the ventilator. They draw ABGs before the trial and 20 minutes after it starts. They watch for changes in the heart rate. Do they have any arrhythmias with it? How's their respiratory status, etc. And if they have no issues, they'll extubate them within 2 to 3 hours, very quickly. Okay? The second piece is an SIMV method. This is the choice for those that have been intubated for weeks to months. Again, the IMV rate is gradually decreased, allowing the patient to breathe more on their own. So if Amber is our patient, and we're going to start, she's been on for a couple of weeks. She's a COVID patient. She's been on for a couple of weeks. I'm going to start allowing her to take more breaths on her own. So now I'll set it so maybe the ventilator only takes 14 per minute and Amber does the other ones on her own. Oh, Amber, she sucks at this and she's not doing very well. She doesn't tolerate it. She just kind of putters out and lets the ventilator do all the work. We may halt her trial for a couple of days. Then the physician may come in and say, I think Amber is stronger, she's healthier, let's try her again, and we'll try it again. And then each day she stays breathing on her own more and more, ventilator less and less, until maybe 3 or 4 days down the road, she's able to sustain her own and we extubate her then. So the SIMV process is longer. It's for patients who have been intubated a longer period of time, and it is not a quick process. RT will do this. They'll do it in conjunction with you as the nurse. So they'll tell you that we're going to try a weaning trial. And they'll know within about 20 minutes whether the patient can do it or not. And if they can't, they'll put them back on the ventilator, same settings. They'll notify the physician, and he or she will say, we'll try again tomorrow. Okay? So our mission is not to knock off the patient. It's to be able to get them to breathe on their own, and sometimes that just does not happen very quickly. Plus, you have to take them all off their sedation medications in order for that to happen. And some of them don't tolerate that very well either. All right, last thing. When do we put them back on the ventilator? Their shortness of breath. They're coughing, but they're not able to expectorate secretions. And their vital signs are no longer stable. That is kind of an independent decision between you and RT. And like I say, you'll put them right back on the ventilator, and then you'll just notify the physician that you have done so and the trial did not work. Okay, when I get off here, I will put the PowerPoints up so you have them. Mrs. Rose wanted all of you to know that tomorrow she will be on this Zoom link at 1 o'clock for anybody that has questions about the material that she's posting for her portion of lab. Okay? And then I will see you tomorrow based on your lab time. So one group will come at 8, one group will come at 9, one group will come at 10. I do have a ticket to lab out on your assignment board that's going to open up here at 1 o'clock. It's not real hard, it's based on today's information. So
Okay.
you should be able to answer it pretty easily.
To clarify, we're only coming for the 50-minute portion.
You got it. I'm going to hand out some stuff, I'm going to demo some things, and then I'm going to let you look at some pieces and parts. Okay? Because Mrs. Rose is not allowed to be in the building yet, not till next Thursday. So she's going to put her stuff online. She's already recorded it, but if you have questions about what you've seen or listened to, she's going to get on Zoom at 1 o'clock tomorrow afternoon, and she can answer any questions, okay? And that's all I've got for you.
So going forward, will we only be in lab for an hour, or is it just because she's not allowed in the building?
If she was here, you would be in lab for a couple hours. Our problem being that there's 40 of you, and the labs can't hold more than like 16. So we have to rotate a 3-group session. So whether you do one group independent, and then you come to Mrs. Rose and I live for the other 2, and then you switch out and you do an independent for 50 minutes while the other 2 groups are live, we can flip them like that. But we can't have 20 of you and 20 of you together at the same time. Okay? Disadvantage of a large class. Okay? If you have questions, come tomorrow with those, okay? That's why I kind of wanted to be here live, so if you have questions about the syllabus or anything, I could clarify it for you.
Real quick, you can probably answer this one. When will the study guides for next week's lecture be up?
So Mrs. Rose, I think, was just making some finishing touches on them, and they should be up probably by tomorrow.
I see them up right now, I think.
Okay.
Perfect.
Thanks, Cole. All right. It's good seeing some of your faces. See you tomorrow. Bye, Jess. Put a smile on that face. Bye, Miss Bianca.